Hello, everyone. This will be your in-service training for our new medical shock management protocol. This protocol is for adults and pediatrics, and we're doing this because you previously had little good direction on actually how to manage patients with medical shock. How much fluid should you give? When should you start a vasopressor? And hopefully, this will provide you with the tools you need to properly resuscitate a patient who is in shock. These are objectives. I will let you review those. If you want to pause and look at them, you can. So there are various forms of shock. We're going to ignore hypovolemic, right? Because that is not what we're going to be treating with this protocol. We're going to review obstructive. We're not going to be treating obstructive shock with this protocol either because you're going to remove the obstruction and fix the underlying causes. Make sense? Um, I really like this chart because it separates the types of shock. It separates it based on the types of shock, but it also shows you the effect that the types of shock has on the body. For instance, if you have a patient with cardiogenic shock, let's say they're having a big MI, their preload is actually increased because the pump is not able to squeeze hard enough to promote forward flow of blood, so that the preload is actually becoming congested. So it's returning back to the heart, but it's not able to actually be ejected properly. The pump function is decreased, and that's pretty obvious. The afterload is increased. So the afterload is the systemic vascular resistance. So the vasculature is actually constricted and clamped down, at least initially, in cardiogenic shock. And because of all this, perfusion is decreased. Distributive is probably the most common form of shock. When we talk about distributive shock, we're talking about vasodilatory shock, which is decreased systemic vascular resistance. So the arteries and the veins are actually flaccid, so to speak. So they're kind of, imagine if the veins were paralyzed. They usually have some kind of vascular tone, but in distributive shock, it loses its tone. And this is actually key to understanding distributive shock and how we should manage it. So the preload is generally decreased because of this loss of vascular tone. Pump function is initially increased. So the strength and the vigor of the cardiac contractions are usually increased to try to compensate for shock early in the phase. Now, the inflammatory disease process in sepsis generally takes a toll on the heart, so eventually it becomes depressed as well, but initially it is increased. So you often see a change in the pump function in sepsis after you administer vasopressors, because imagine if that heart is very vigorous, it's ejecting, it's humming away, so it's contracting, its contractions are very strong. Then you increase the afterload. You actually give it something to pump against. So if you increase it by adding fluid or by adding pressors, the actual cardiac dysfunction is then uncovered because it goes from hyperdynamic to hypodynamic. So if we increase the afterload, sometimes we might have to increase the strength of cardiac contractions by adding an inotropic agent. But in distributive shock, the afterload is decreased because of the poor vascular tone. A question that we want to answer is, how much fluid should you administer before starting a vasopressor? Historically, we would just give a bolus after bolus after bolus after bolus, and we would keep giving fluid boluses either until the blood pressure went up or the patient's lungs filled with fluid. And now we know better. We know that that is bad. We want to give just enough and not a drop more. But how do you determine how much is just enough? Well, that is the $1,000,000 question. So if you look, when you're administering volume, when you're administering fluid or volume to a patient, you're filling the vasculature. So you're initially filling the vascular, which is great, assuming that it is more of a more of a hypovolemic state, like the volume or the fluid is actually leaking out of the capillaries, as opposed to more of a vessel diameter problem. And we were taught that it's a little bit of both. But the problem is that it is actually more so an issue with the vessel diameter, and the leaky capillaries, or the fluid leaking from the vessels, is more of an iatrogenic problem. So it's more of a problem that we cause, and not as much of a problem with the disease process itself. So we really need to understand venous capacitance. So why do I have a picture of a cheetah here, you may ask? So this cheetah actually has the ability to convert volume that is not stressed. So we call unstressed volume, or we call volume that is not stressed, unstressed volume. So imagine all of the vessels in your body, all of the veins, generally can hold quite amount of volume, and at any given time, if we go into a fight or flight response, our body is capable of turning all of these veins that are not stressed, all of these veins that are not stressed, and stressing them. So adding stress on the vasculature to increase preload or venous return, right, that should hopefully augment cardiac output, assuming that there is no cardiac dysfunction. The cheetah can actually take its spleen, which is fairly large, and compress it down to the size of a fist. And that is how the cheetah can mount such a response in its speed, at least for a short duration. So that is what we're really doing. Other than augmenting cardiac output, we are augmenting cardiac output some when we're adding vasopressors. But if we go by if we appreciate the issue with distributive shock as more of a vessel diameter problem and as less of a hypovolemic problem, then it makes sense why you could just why it makes sense why you don't need to administer as much volume as you think you do, and why vasopressors can actually utilize the patient's own compensatory mechanisms that are dysregulated because of the disease process to work for them. So imagine that we have a cylinder, and this cylinder is not fixed, so it is capable of expanding or contracting. So what we're doing with this flexible, if you will, container when we add volume is we're just stretching it out a little bit more. We're not actually contributing to the process of preload, so we're not really sending that much fluid back to the heart in distributive shock states. And we might have to administer a large amount of volume before it can actually send blood back to the heart. So what if we had this container that was already full of volume, and instead of just adding more and more and more isotonic solutions to it, we added a vasopressor agent that could actually shrink that shrink that unstressed volume and turn it into stressed volume and improve venous return back to the heart. When we're talking about sepsis, sepsis is the stereotypical distributive shock that we all talk about, and rightfully so, because it's the most common form of distributive shock. It was so bad that there was a group of people that formed the Surviving Sepsis, or created a Surviving Sepsis campaign, and they come out with these reportedly evidence-based performance measures that you should try to achieve when treating patients with sepsis. And here they are listed. However, they say that you should begin rapid administration of 30 mLs per kg crystalloid for hypotension or lactate level greater than greater than or equal to 4 millimoles. So they say that you should administer it if the patient's hypotensive or if the lactate is elevated. So should we be administering 30 mLs per kg of isotonic solutions to every single patient, regardless or not if they are actually responding to that? The short answer is no. The long answer is no. It's not good practice to generalize every single guideline to every single patient population, because we know that we can't treat every single patient the same, and not every patient responds to therapies exactly the same way. But they do say to apply vasopressors if hypotensive during or after fluid resuscitation to maintain a MAP greater than or equal to 65. That sounds pretty reasonable, because it's not good to allow a patient who is persistently hypotensive to remain hypotensive. At some point, we would have to transition from giving fluid therapy to giving vasopressor therapy. And knowing when exactly that transition is the very difficult part. There was a recent article that was published in JAMA, and this was a landmark trial, and it received a lot of hype on social media. So basically what they did is they took 424 patients, they randomized them to two groups. They treated the patients based on peripheral perfusion or a lactate. Okay? And what they found was that the patients who were resuscitated based on their peripheral perfusion did better. So less patients died. The mortality in this group was 34.9%, and the mortality in this group was 43.4%. Even more interesting is that the patients in this group, the peripheral perfusion group, were resuscitated based on fluid responsiveness. So they administered isotonic solutions, and if there was an improvement, then they continued to administer the fluid until the patient stopped responding and stopped improving, at which point they started vasopressor therapy. The lactate group was not resuscitated in this protocol. So we do see a decrease in mortality with resuscitating patients based on their ability to respond to volume administration, or their inability to respond to volume administration. In fact, there are quite a few studies showing that amongst patients with septic shock, those that received early vasopressor therapy had a decrease in mortality compared to those who had delayed vasopressor therapy. So there is something about not flooding a patient with a arbitrary amount of fluids that actually helps them survive more often than those that get flooded. And why is that? There are actually a lot of reasons why fluid can hurt a patient, and why we should be shifting our paradigm of arbitrarily administering bolus after bolus after bolus, thinking that something is going to be different. One of the main reasons has to do with the permeability of the cells. And what we've come to find out is that the cells do leak fluid in septic shock. But what we have also learned is that by administering large volumes of crystalloid, we damage a protein called the glycocalyx. And the glycocalyx is actually responsible for membrane integrity. So when we administer large volumes of crystalloid, we're actually hurting the cellular membranes and causing more and more fluid to leak. And we already know that only 1/3 of the volume that we administer actually stays in the vascular space. So if we actually want to give 1 liter of fluid, we would need to give 3. Although I hope that after this presentation, you would realize that the patient does have volume sitting in their body that we can utilize if needed. So if you have two patients, patient number 1 and patient number 2, Patient number 1 has a sort of soft blood pressure, heart rate's 120, the extremities are warm, and the patient is alert and oriented. How would you treat this patient? Well, the blood pressure is marginally low. The heart rate's 120, and let's assume that they have some sort of infection. Okay, this patient is clearly in shock, right? So they're somewhat compensating for that shock because they have mounted a compensatory response by increasing their heart rate, but their blood pressure is soft. That patient does need to be resuscitated. With this patient, we could probably say that we have quite a bit of time to figure out if they're going to respond to fluid or not. So we can give little 250 milliquat or 250 ml aliquots of fluid to see what type of response they have with that fluid administration. We can take a more cautious and deliberate approach with resuscitating them. Now, if we have patient 2 who presents with a blood pressure of 78 over 40, heart rate of 80, clear breath sounds, cool extremities with an altered mental status, then they have signs of end organ perfusion, and we need to be a little bit more aggressive with them. So we may still give the 250 ml aliquots of fluid bolus, but we may shorten the intervals, we may give it very rapidly, and if the patient does not respond, we may have a lower threshold to start a vasopressor. One, because they're not responding, but two, their heart rate's a little low, and it seems that they're not mounting a significant compensatory response compared to patient number 1. Now, as mentioned previously, there are some patients who respond to fluid and there are some patients who don't. So how do we know if a patient's going to respond or not? Now, there are multiple ways to do this, but imagine that you have the patient on end-tidal CO2 and you're wanting to administer fluid. The end-tidal CO2 starts off at 20. And why would the end-tidal CO2 initially be low? Well, let's imagine you have a patient in cardiac arrest. That patient in cardiac arrest has a sudden increase in their end-tidal CO2. Let's say it goes up from 15 to 40. That's more than double what it was initially. There's a good chance that that patient's heart started beating on its own, and the patient has returned to spontaneous circulation. Now, anytime you improve perfusion to the lungs, you have more CO2 going to the lungs. So the end-tidal is not just reflective of the CO2 concentration in the body, but it's also reflective of the patient's cardiac output. So the converse is also true. If you have a patient, let's say it was a major trauma patient, and they present with an end-tidal of 30, which is low to begin with, but it slowly starts trending downward, you know that that patient is likely decompensated. So we've got a patient on end-tidal. They initially have an end-tidal of 20. We give a small bolus of 250. It goes up marginally to 22. We give another bolus of 250. It goes to 24. We know that the patient is actually responding to that fluid clinically, and it keeps going. So there's a lot of good data on this. Now, I want to direct your attention to this top study, number 1 here. It says changes in end-tidal CO2 could predict fluid responsiveness in the passive leg raising test. So what is the passive leg raising test? It's when you have a patient who is laying supine and you actually raise their legs in the air. So what you're doing is you're translocating volume that is in the legs, and you are sending it back to the core. So you can send about 500 mLs back to the patient's core just by raising their leg. We don't do it routinely in shock patients anymore because it's very transient and it goes away. But if you're monitoring CO2 in a patient and you do this, even that transient effect should at least transiently increase the end-tidal CO2. And if you see an increase in end-tidal CO2 by doing the passive leg raise test, then theoretically you know that the patient will respond. They will be able to increase their cardiac output sufficiently enough by that improvement in venous return. So, but they go on to say not in the mini fluid challenge test. So for whatever reason in this study, raising the legs did show an increase in end-tidal CO2, which predicted fluid responsiveness, but a mini fluid challenge test did not. There was another study that looked at this, and then there was another study down here that actually said that change in end-tidal carbon dioxide outperforms other surrogates for change in cardiac output uh, during fluid challenge. So does this mean that we should use end-tidal CO2 in isolation to determine if a patient's going to respond to a fluid challenge or not? Probably not, but it would be good to use this in combination with other clinical assessment findings. So use your capillary refill time, feel the legs, feel the knees, see if the knees are cold or warm, because the knees are actually a good reflection of the patient's perfusion status. Cold knees is bad, warm knees are good, and the patient generally has good perfusion. You can even use a blood pressure. Does the blood pressure go up a little bit? Does it not go up? Does it go up marginally? Is the heart rate coming down with the fluid administration? You have to use all of these things in combination. We also need to know the pharmacokinetics of various vasopressor and inotropic agent. So we usually classify things as alpha 1, beta 2, alpha 2. I think that that's very confusing. I prefer to call something a pressor or an inotrope or an inopressor, because some things do increase the strength of cardiac contraction and squeeze the vessels down. Dobutamine is probably one of the purest inotropic agents out there, so it's mostly just an inotrope. Whereas phenylephrine, all the way to the right, is mostly a pressor. So it's mostly a pressor. Everything in between has a little bit of both. Now, for our purposes, we want something somewhere in the middle. Dopamine can either go this way or it can go this way, depending on the dose. And a lot of drugs are dose dependent. Even epi and norepi is dose dependent. But epi has mostly the effect on cardiac output by increasing the strength of cardiac contractions. But as we go up in the dose, it is more of a pressor agent, so it shifts this way a little bit. Now, do we want anything that's strictly a pure pressor or a pure inotrope? The answer is no, because when we increase the afterload, we know that if there is any cardiac dysfunction that was not present because it did not have anything to pump against, when we increase the afterload, that cardiac dysfunction reveals itself, and then you would have to add on an inotrope anyway. So it's probably best to add something that's a little more balanced and acts as a pressor and an inotrope. Now, when it comes to choosing the right vasopressor, right inotrope for the job, this list includes the preferred first line vasopressors, first and second line. You'll see cardiogenic shock. First line is norepi. Distributive, it's norepi, and then in anaphylaxis, it's epi. So generally, norepi is preferred for no reason other than it doesn't have the arrhythmogenic effects as norepi or dopamine, meaning that it does not increase the heart rate as much as dopamine or norepi. And there are a few other minor reasons, but we have to ask ourselves, is it clinically relevant? So is giving norepi, does it improve or decrease mortality compared to norepi? And the answer is no. When we're talking about patient-centered outcomes, does it really make a difference in the patient's morbidity or mortality? Does it improve their outcome? And the answer is that epinephrine is just as good as norepi in the vast majority of studies. Even when you combine dobutamine and norepi, epi is just as good. Epinephrine and norepinephrine are always better than dopamine. Yes, epinephrine will increase the heart rate, but to a less so degree than dopamine. And dopamine actually does decrease mortality in some shock patients. And there are quite a few trials. When you look at the efficacy, the safety, even if you're just targeting a certain map, there is no difference between epi and norepi and dopamine, or epi and norepi. Sometimes when we give pressors, we expect a certain effect. We have to understand, though, that not every patient responds the same way. So imagine we're transporting norepi and we're going to expect a certain response out of that. That doesn't mean that that patient is going to respond immediately or respond the way that we expect with an increase in the cardiac output or an effect on the blood pressure. The same holds true for epi. It's also true that some patients respond to epi better than norepi, and some patients respond better to norepi than epi. Sometimes you just don't know until you actually challenge the patient and see how they respond. Now, how are we going to administer this? Traditionally, you would put 4 milligrams of epi in 250 mLs or 4 milligrams of norepi in 250 mLs. Now, what's the problem with this? Well, the main problem is that that is a very concentrated solution and you really need a pump. If and when we get IV pumps, then that would be an appropriate way to administer the medication. But I think that there's a better way for EMS. And when we're administering an epi drip, the best way right now without a pump is to take 1 milligram of epi. It really doesn't matter if it's epi 1 to 1,000 or epi 1 to 10,000, which actually we're supposed to be calling it 1 milligram in 10 mLs or 1 milligram in 1 ml. So we want the IV epi, the cardiac epi, and we want to put that in 1 liter. Okay. When we take 1 milligram and we put that milligram in 1 liter, our concentration is then 1 mic per ml. 1 mic per ml. If you didn't have a liter bag and you put it in a milligram in 500 cc's, then your concentration would be 2 mics per ml. Either way, it would work if you can calculate it that way, but it's much safer to standardize it and just say we're going to be putting 1 milligram of epi in 1 liter. So how do you calculate that? How does that work out? So you know that 1 milligram is how many mics? Okay, it is 1,000 mics, micrograms. 1 liter is 1,000 milliliters. So if you put this in that, what is your concentration? Your concentration is 1 microgram per ml. So that's how we got the concentration. So how do we administer it? Well, first of all, you've got to calculate it based on weight. How many mics a minute do you need based on protocol, which is based on the patient's weight? But to calculate it, if you're using a 10 drop set, 10 drops set, so 10 drops equals 1 ml, right? And then 1 ml equals how many mics? Well, 1 mic. So if we want to give 1 microgram per minute, we need to give 10 drops. Using a 10 drop set, if we want to give 2 micrograms per minute, we need to give 20 drops. If we want to give 3 mics, then we want to give 30 drops, and so forth. And if you ever have any trouble with these drug calculations, come to me and we will work through it. Now, what if you have a patient that is crashing? They're peri-arrest, their heart rate's trending down, their blood pressure's trending down, they're unconscious, and you know that you need to immediately resuscitate them. What is the best way to do that? Well, the best way, and probably the quickest and most accurate way, is to mix what we call a push dose epi. So to do this, you take a 10 cc syringe or 10 cc flush with 10 mLs. You expel 1 ml. So you take 1 ml out. Then with your epi, you insert that into epi. Okay. You see this blue stopper here? you just poke it through there and you draw out 1 ml. You take that 1 ml, draw it up into the 9 mLs, which now makes it 10 mLs. So what is your concentration then? Well, if you realize that every ml of epi, 1 ml is 100 mics, because there are 100 micrograms, there is 1 milligram in 10 mLs. So that makes each ml 100 mics. So what we're doing is putting 100 mics in 10 mLs. So that is 10 micrograms per ml, assuming that you shook it up enough. 10 micrograms per ml. So how much do you give? Well, what we're going to recommend is that you administer fluid in 250 ml aliquots. Okay, so you give boluses of 250. That doesn't mean that you can't give it rapidly and you can't repeat it, but you're going to give 250, reassess, give 250, reassess, and look for any improvement. If the patient responds, then good, but if they don't and you have given 1,000 mLs of fluid, then you can consider starting a vasopressor. You'll see that we have norepi listed here. Okay, and it's based on weight. It's a weight-based medication drip, and so is epi. You're going to titrate these to a MAP greater than 65. So you'll see that we have in our protocol norepi, but we're not going to carry it unless there's an IV pump available. So you've got to have an IV pump, or you can use it in a facility if they've already established it, or you can request that they initiate a norepi infusion if you think that they need it, and then you can titrate it. All right, you can go to the low end of the weight-based or the high end. We plan on getting an IV pump, so I wanted to go ahead and get this in the protocol, but I did just add this caveat. So right now you will be doing epi drips. You'll mix it the same, but you'll calculate how many mics per kg you need and start there and titrate. Or if you have a patient that's crashing and you think that they need epi now or they need a pressor now, then you can do push dose. You can give 10 to 20 microgram boluses, which should be 1 to 2 mLs, assuming everything was mixed properly. And you can give that every 2 minutes. And you're looking for the MAP of at least 65. Okay. For pediatrics, if they don't respond to fluid, if they don't respond to 20 mLs per kg of fluid, so you're going to give 20 mLs per kg, and you're going to repeat to a maximum of 60 mLs per kg. If they don't respond to that, we want you to contact medical control and ask them what you should do. Okay. Now, anytime you're mixing anything up, always use a medication administration cross-check. So hold the vial up, hold the syringe up, and ask your partner, ask somebody to cross-check that medication and make sure that you mixed it correctly. There have been some reports of people regularly mixing up push dose epi incorrectly, and this could be deleterious to the patient. So this is nothing that's benign, so you want to ensure that you're doing a cross-check, and I want you to document in your report that a cross-check was performed. Now you also want to label it, so you don't want to mix up push dose epi or even an epi drip and someone thinking that it's not a pressor and either trying to flush a line with it or opening up the dial wide open, thinking that they're given a fluid bolus. So always, always, always label, and always, always, always do a cross check. And we will get some labels printed for this. And like with every lecture, I usually conclude with, if you ever have any issues or you're not, or you're uncertain about what you should do, always contact medical control. And if you ever have any questions or need help with anything, you let me know. Thank you.